Okay, good evening, everyone. You are all welcome. So this is the second batch in my unit that will be having the virtual unit presentation. And of course, as I told you all today in the theater, you should take it seriously because this might be the only time you'll come across some of the topics we'll discuss as presentation. So every member of the group should take their presentation seriously and don't limit your readings to the topics you are given to present. You should try and read all other topics so that you can make meaningful contributions and ask questions, especially when comments are made from your supervisors. And when you are making a presentation, you should know that the first slide should indicate the topic of your presentation, your names, the name of your moderator, your department, and your school. Don't just write the topic as well as the just your name, because it will just appear as an anonymous presentation. And you also include the dates you presented, because if you are presenting the same topic, maybe 3 years later, when you are in S3, the content of the presentation will be different because by then you have done so many postings and you have grasped a lot of knowledge and pathogenesis of the common conditions you come across. So that is a correction subsequent presenters will make. So, of course, even though as S1 student, I don't expect knowledge in depth, but you must strive as much as possible to demonstrate that. Where you make mistakes, they will be corrected. So hope the presenters are ready.
Yes, sir.
So who is the first presenter? You can go ahead and start your presentation.
Okay, good evening, sir, and my fellow. Hello, good evening, sir, and my fellow classmates. I am Aisha Amin Oguso, a presenter from the first group presenting today on pathogenesis and management of acute intestinal obstruction. The next slide is our outline, which consists of introduction, definition, and classification, etiology, pathogenesis management, factors affecting prognosis in acute intestinal obstruction, follow-up, conclusion, and our references. So intestinal obstruction is defined as a blockage that prevents the normal passage of contents through the intestines. It is one of the commonest surgical emergencies, and it's a condition in which there is stoppage of the onward passage of intestinal contents, which are gases, digestive juices, and food. This can occur in either the small intestine or the large intestine and can result from various causes, including mechanical blockages or functional issues. Acute intestinal obstruction is defined as a sudden onset of this blockage, which can lead to severe symptoms and require immediate medical attention. So epidemiologically, it is more common in adults than in children, with a higher incidence in males. The most prevalent cause includes adhesions from previous surgeries, hernias, and tumors. In terms of age distribution, it tends to occur more frequently in individuals over 60 years old, primarily due to age-related changes in the gastrointestinal tract and a higher incidence of malignancies. Geographically, the incidence can vary, with higher rates reported in developing countries due to a greater prevalence of untreated hernias and infections leading to adhesions. So intestinal obstruction can be classified into two types, or it may be classified into two types. The first one is dynamic, also known as mechanical obstruction. In this type, peristalsis is active but is working against a mechanical blockage. That is, something is actively blocking the intestine, so leading to obstruction. It is due to a mechanical obstruction of the intestinal canal and is associated with abdominal pain. This can occur in both acute and chronic forms. The second classification is the adynamic, also known as the paralytic obstruction. This occurs when there is a lack of peristalsis, leading to a functional obstruction without a physical blockage. It is due to paralysis of the intestinal musculature and it's characterized by absence of pain. Dynamic obstructions are often caused by factors such as adhesions, hernias, and tumors, like I've mentioned before, while adynamic obstructions can result from conditions like ileus or nerve damage. Understanding this classification is crucial for effective diagnosis and treatment. Dynamic or mechanical obstruction can be further classified into three categories based on their onset and progression. The first is acute obstruction, which is sudden blockage with rapid onset. And the second is chronic obstruction, which is the gradual blockage with slow and progressive symptoms. And the third is acute on chronic obstruction, which is a sudden worsening of a pre-existing chronic blockage, where the already narrowed intestinal canal becomes completely blocked. So causes of acute intestinal obstruction. There can be intraluminal causes, extramural causes, intramural and mesenteric vascular occlusion. For the intraluminal causes, that is the cause of obstruction is within the lumen of the intestine. Examples can be ascariasis, foreign objects such as coins, and pedunculated tumors, impacted feces. For the extramural, it means the cause of the blockage is outside the wall. And a few examples can be a strangulated hernia, and it can be external or internal. It can be external constriction, adhesions and bands, and volvulus. The third one is the intramural cause, that is the cause of obstruction is in the wall. An example can be atresia, anorectal anomalies, intussusception, aganglionic megacolon, and internal constriction, such as tumors or inflammatory lesions like diverticulitis, Crohn's disease, ileocecal tuberculosis, and stenosis at site of strangulation. And then the last one is mesenteric vascular occlusion, also known as mesenteric ischemia, where the mesenteric vessels become blocked and leading to vascular occlusion. So for the pathogenesis, intestinal obstruction can occur in one, simple obstruction. In the bowel below the obstruction, normal peristalsis and absorption continue until the contents are either absorbed or passed out, causing the bowel to collapse. Above the obstruction, however, the bowel becomes distended. Initially, peristalsis is vigorous for several days, but if the obstruction is not relieved, the increasing distension leads to a loss of peristaltic activity. Distension occurs due to accumulation of gases and fluids. Most of these gases come from swallowed air, while some are products of putrefaction and fermentation of intestinal contents by bacteria. And others and others result from diffusion from the blood. The fluid accumulating are primarily digestive juices, including saliva, gastric juices, bile, and pancreatic secretions. This accumulation happens partly due to the loss of absorbing surface of the bowel below the obstruction, and partly due to the disordered fluid and electrolyte transport in the obstructed segment. The rate of absorption of water, sodium, and potassium by the obstructed bowel decreases steadily and typically ceases after about 12 hours. Conversely, the rate of secretion of these substances by the intestines rises significantly over time. The degree of distension is influenced by the level of obstruction. In high bowel obstructions, the accumulated fluid can quickly reach the stomach, leading to vomiting, while in low obstructions, there is more space for fluid accumulation, leading to distension. So under simple obstruction, there can be dehydration and electrolyte imbalance. These are due to vomiting, accumulation of gastrointestinal secretions in the bowel lumen, sequestration of fluid in the bowel wall and peritoneal cavity, diminished oral intake, and decreased absorption. Most of the gastrointestinal secretions, normally amounting to 7 to 10 liters in 24 hours, but increased in obstruction is lost to the body through vomiting or sequestration in the obstructed gut. The fluid secreted into the obstructed gut has a higher concentration of potassium and sodium. There's also loss of ECF, extracellular fluids into the peritoneum and bowel wall, which results in hypovolemia, shock, hyponatremia, hypokalemia, and renal failure. Then the strangulated obstruction. It is important to note that the consequences of intestinal obstruction are not immediately life-threatening unless there's already a superimposed strangulation. So when strangulation occurs, the blood supply is compromised and the bowel becomes ischemic. Ischemia from direct pressure on the bowel wall from a constricting band, such as a hernial orifice, is easy to get. Distension of the obstructed segment of bowel results in a high pressure within the bowel wall. This can happen only when part of the bowel is obstructed, as seen in Richard's hernia. Venous return is compromised before this arterial supply, so the resultant increase in capillary pressure leads to impaired local perfusion, and once the arterial supply is impaired, hemorrhagic infarction occurs. As the viability of the bowel is compromised, translocation and systemic exposure to anaerobic organisms and endotoxins occurs. So the morbidity and mortality associated with strangulation are largely dependent on the duration of the ischemia and its extent. Elderly patients and those with comorbidities are more vulnerable to its effects, although in strangulated external hernias, the segment involved is often short. Any length of ischemic bowel can cause significant systemic effects secondary to sepsis and obstruction proximal to the obstructed bowel can result in significant dehydration. So this next slide is showing us a hernia that became strangulated and intestinal obstruction as a result of adhesion, then intestinal obstruction as a result of volvulus, and intestinal obstruction as a result of intussusception. For the last pathophysiology, we have the closed loop obstruction. This situation arises when there is an obstruction at both the proximal and the distal ends of the bowel, leading to a closed loop obstruction. In this case, the distension is mainly confined to the closed loop, and the distension proximal to the obstructed segment is typically not very pronounced. A classic example of this type of obstruction can occur with a malignant stricture of the colon, while the ileocecal valve remains competent, which is observed in up to 1/3 of individuals. This condition can develop even with lesions located as far distally as the rectum. The distended colon's inability to decompress into the small bowel leads to an increase in the luminal pressure, which is more significant at the cecum. At this pressure bills, it impairs blood flow in the bowel wall. If left unrelieved, this process can ultimately result in necrosis and perforation of the affected bowel segment. And here we can see that the closed loop obstruction, both the proximal and the distal end have been strangulated, leading to a markedly distension within the closed loop. Yeah, thank you.
Good evening, sir. Good evening, everyone. I'll be taking management. So, under management, start with the history. The patient will present with, first of all, pain, which is the first symptom. It is severe cramping, rhythmically intermittent and colicky. In small bowel obstruction, it is central in position, while in large bowel obstruction, it is hypogastric. Each spasm of pain waxes rapidly, lasts for several seconds, and more slowly wanes. In between spasms, there is relief. In case of strangulation, there is persistent pain between the spasms of the colicky pain. There's also vomiting, which occurs early and is perfused in high obstruction, but may be late or absent in low obstruction. Initially, the vomitus is colorless or greenish, then becomes light brown. In late stages, it may be dark brown and feculent due to bacterial decomposition of the intestinal contents and blood. Then there is also absolute constipation, which is present from the outset, meaning there is failure to pass flatus or feces, although the patient may pass one or two normal stools as the bowel below the obstruction empties. Like in Richard's hernia, however, feces and flatus may be obstruction. Then the distension is primarily in the central abdomen. In the colonic obstruction, it is in flanks. In case of volvulus of sigmoid, in the case of volvulus of the sigmoid colon, distension can be very gross and may fill the entire abdomen. On examination, the positive findings that will be seen are visible peristalsis on maybe presence of pitched bowel sounds. Then the hernia orifices and rectum must be examined since they may be sites of obstruction. A femoral hernia in a fat patient may escape notice unless specifically looked for. A scar on the abdomen must be looked for, as this may suggest obstruction secondary to post-operative adhesion. Then rebound tenderness and some guarding due to serosal hyperemia or inflammation along with a mass are suggestive of strangulation. These signs are absent in simple obstruction. Then general signs of dehydration, shock, and electrolyte imbalance must be sought, which include sunken eyes, dry tongue, dry inelastic skin, rapid pulse, low blood pressure, and mental confusion. Investigations. First is enema. It's a result. The result is a simple enema is usually poor. If it is good, because the bowel distal tend the obstruction, which was not emptied before the enema, But then if it's repeated after half an hour and it's poor, it means that the obstruction exists. So for imaging studies, an X-ray of the abdomen can be done. An upright abdominal X-ray can reveal air fluid levels and distended bowel loops indicating obstruction. An ultrasound can be done. This can be useful especially in children to identify the site of obstruction and assess for complications like strangulation. Then a CT scan can also be done. A CT scan of the abdomen is often the most definitive imaging modality, providing detailed information about the cause and the location of the obstruction. So for the laboratory tests, complete blood count can be done, which helps detect for signs of infection or dehydration. An electrolyte panel can also be done, which is important to assess for electrolyte imbalance due to vomiting and fluid loss. Blood urinary nitrogen and creatinine tests can be done to evaluate kidney function, which can be affected due to dehydration. Endoscopy. In some cases, an endoscopy may be performed to visualize the intestinal lumen and possibly relieve the obstruction. Then contrast studies. If the obstruction is not complete, a contrast study may help to determine the patency of the bowel. These investigations are crucial for determining the cause and appropriate management of acute intestinal obstruction. So for treatment, before relieving the obstruction, it is crucial to stabilize the patient's overall health by correcting fluid and electrolyte imbalances through hydration and electrolyte replacement, and also initiate antimicrobial treatments to prevent unmanaged infection. Only after stabilizing the patient's condition can effective obstruction relief be achieved. So there are three stages of treatments that can be done. First one is general measure, conservative management, and operative treatment. So under general measures, we have correction of fluid and electrolyte, correction of fluid, electrolyte, and metabolic imbalances, nasogastric decompression, sedation, and antibiotics to combat infection. Under correction of fluid, electrolyte, and metabolic imbalance, fluid and electrolyte deficiencies need to be actively collected using Ringer's lactate and dextrose saline solution along with dextrose water. Potassium chloride should be added if urine output exceeds 30 ml per hour. In case of severe strangulation where a significant amount of blood may be lost, blood transfusion may be required following the initial crystalloid administration. Any fluid lost through aspiration should be replaced with gastrointestinal replacement solution. Monitoring of pulse and blood pressure should occur every 15 minutes, while urine output should be checked hourly. Central venous pressure monitoring can be helpful. A fluid balance chart should be maintained, and serum electrolyte and blood urea levels should be checked twice daily. Nasogastric decompression. Gastric aspiration is essential for removing swallowed air and intestinal contents that may regurgitate into the stomach. This process helps decrease bowel distension, which in turn minimizes the secretions of water and electrolytes from the intestine. Additionally, it reduces the risk of aspiration into the trachea and bronchi during anesthesia induction. Morphine 10 to 15 mg or pethidine 100 mg should be given to relieve pain. Antibiotics to combat infection. The growth and spread of bacteria should be controlled to halt using broad-spectrum antibiotics like ciprofloxacin or cerazime or ceftazidime, along with metronidazole or ceftriaxone. Then under conservative management, simple obstruction of the small intestine due to adhesions after surgery usually respond well to conservative management. Surgery is generally not recommended because it can result in formation of new adhesions. However, laparotomy should be performed if the obstruction persists indicated by an increase in distension or aspiration, worsening abdominal pain and tenderness, or an elevated pulse rate. Then operative treatment. In case of acute obstruction, there is often a significant risk of strangulation, making surgical intervention typically urgent. The operation is carried out as soon as the patient is full enough for it. The type of surgery depends on the cause of the obstruction. For example, a herniatomy may be performed for a strangulated hernia, while a laparotomy is indicated for an intra-abdominal causes. During laparotomy, the abdomen is usually opened via a median incision centered at the umbilicus, and the cecum is examined. If the cecum is distended, the obstruction is likely in the colon. If not, it is in the small intestine. The collapsed distal segment is traced to the dilated portion where the obstruction occurs at the junction of these segments. Appropriate measures such as adhesiolysis are taken. If the obstructed bowel is gangrenous, it is resected and continuity is restored through end-to-end anastomosis. A non-viable gut appears flabby, dull, lusterless, and more and maybe dark purple, black, or gray. Peristalsis is absent even with stimulation, arterial pulsation in the mesentery is missing, and signs of venous thrombosis may be present. There will be no color change after administering oxygen or apply a warm saline pack to the bowel. Post-operation, intravenous fluid therapy and gastric aspiration are maintained until bowel sounds are heard or flatus is passed. So factors affecting prognosis of acute intestinal obstruction. The first one is interval between onset and time of treatment, then the nature of the obstruction, the level of the obstruction, adequacy of preoperative correction of fluid and electrolyte imbalances, non-viability of the bowel, causes of obstruction, pre-existing disease, and age. Then follow-up after treatment of acute intestinal obstruction involves several important steps. First one is clinical monitoring. Patients should be closely monitored for signs of recurrence of symptoms such as abdominal pain, distension, or changes in bowel habit. Then physical examination. Regular physical examinations are necessary to assess for tenderness, rebound tenderness, and any palpable masses that may indicate complications. In vital signs, monitoring vital signs including temperature, pulse, blood pressure, and respiratory rate helps detect any sign of infection or systemic complication. Nutritional assessment. Evaluate the patient's nutritional status and ensure they are gradually reintroducing oral intake as tolerated, starting with clear fluids and progressing to regular diet. Imaging studies. If there are concerns about recurrence or complications, follow-up imaging studies such as abdominal X-rays or CT scans may be warranted. Patient education. Educate the patient about signs and symptoms to watch for that may indicate a return of obstruction or complication, such as severe pain, vomiting, and inability to pass gas or stool. Follow-up appointments. Schedule follow-up appointments to assess recovery and any further management needed, especially if the obstruction was due to an underlying condition that requires treatment. These follow-up measures are crucial to ensure a complete recovery and prevent any further complications related to intestinal obstruction. Conclusion. In conclusion, acute intestinal obstruction is a serious medical condition that requires prompt diagnosis, and treatment. It can result from various causes, including adhesion, hernias, tumors, or volvulus. Early identification through clinical assessment and imaging studies is crucial for effective management. Treatment options may include conservative measures such as bowel rest and decompression or surgical intervention if necessary. Post-treatment follow-up is essential to monitor for complications and ensure a full recovery. Understanding the signs and symptoms can help in seeking timely medical attention, ultimately improving outcome for patients experiencing this condition. Then our references were from Badger's Principles and Practice of Surgery, including Pathology in Topics, Volume 2, 5th edition, Lillies and Love Self Practice of Surgery, edition 27th and 25th edition, and e-learning. Thank you.
So, well done. I must commend both of you for this detailed presentation. And secondly, you have a very good outline, and the outline is well followed. Of course, this will help you in your essay writing, because if you have a very good outline in your essays, you do well. Some of the examiners will look at your outline. If you have a good outline and you follow the outline correctly and giving correct information, you are going to pass that essay. Notwithstanding, there are some few comments in your slides as well as some information on the presentation that are not too relevant, especially when dealing with an acute intestinal obstruction. And I'll also highlight those areas where you need to pay more attention when dealing with a patient with an acute intestinal obstruction. But before then, I'll open the floor for questions, comments, and contributions to the presenter. So if you have a question, you can signify by raising your hand, or you unmute yourself and go ahead and ask your questions. Then the presenters will respond to the question before I make my comments. So now the floor is open for comments. Yes, you can go ahead and ask your question if you have any. Just unmute yourself and go ahead and ask your question. So it means you don't have any question. So if you don't ask questions, it means you did not read around the topic, or you did not even understand what they are talking about. Okay, notwithstanding, because of time, let me just go ahead and make my comments, then we'll conclude. Now, as commended earlier, you did well for the presentation. We must thank you for listening to you and the comments. We must thank you and the effort you put towards preparing your slide in a very short notice of within 24 hours. So my comments regarding your slides. Your slides are too bulky. Even though this is just an S1 presentation, but you should know when you are making a PowerPoint presentation, you shouldn't fill up the slides with a lot of information because the slide will be overcrowded and it will become uninteresting. And it will be very difficult to follow the audience. You will not carry the audience along. So in a PowerPoint presentation, you are not supposed to load all your stuffs there. Of course, you read that and have the stuff at the tip of your fingers, such that anything you are asked, you will be able to respond. But you should make your slides precise and in a bullet form. Just highlight the main points. Okay, so that is the first comment regarding your slides. Now, you use, secondly, regarding the reference, those are the common reference textbooks we use generally for surgical education here in Nigeria. Those are very good books, highly recommended textbooks. If you confine yourself to those reference material you used, I think you have a very good grasp of surgery in general. So I must commend you for that also. Thirdly, when making presentation, it shouldn't just be like you are just reading the entire slides. You just make up a presentation and you are just casting as if you are casting a news, just reading through the slides. If it will appear as if you have not internalized the message you are telling us. And if you come across new words in the presentation, before the presentation, you have to master those words so that you don't come at the day of your presentation, you start struggling to pronounce those words. It means you have not mastered your slides. So these are some certain things you need to pay attention to as your clinical presentation continue. Okay, I will not go too deep in the discussion, but subsequently we are going to highlight in depth. Now, you almost highlighted all the important aspects every medical student is supposed to know in the slides. Okay, so this slide will serve as also a reference material for reading for you, but it shouldn't be a kind of a way you will answer questions. We'll make some modifications on the slides and some corrections on the slides. Okay, so I will ask each of the presenter one question. Then I will now make few corrections Then we'll now end the presentation. So for the first presenter, what is the difference between a high obstruction and a low obstruction? And how do you differentiate them? So the first presenter, Aisha, go ahead.
Yes, sir. Okay. A high obstruction is an obstruction that occurs in the higher bowel. Oh, sorry, sir. Yes. In the higher bowel, while the low obstruction is the one that occurs in the lower bowel. And how we differentiate them is
That is not clear. What do you mean by high bowel and low bowel? You have to be very specific and precise so that we'll understand what you mean. What is
like the high bowel is the small intestine, while the lower bowel is the large intestines.
no? Which part of the small intestine is considered as? There is a landmark. If you read those reference materials properly, when talking about high intestinal obstruction and low intestinal obstruction, there is a demarcation. You
Yeah,
use differentiating both because this is very important. Okay, so you failed the first part of the question. Okay, I assume you don't know the line of
ligament of
differentiation.
threads.
No, that is for bleeding. Upper GI bleeding and lower GI bleeding. That is not for intestinal obstruction. Now,
Okay.
how do you differentiate the two?
Okay. In upper GI obstruction, there is
No, I did not say upper
vomiting.
GI. High and low.
High obstruction, there's usually vomiting and very colicky pain. And in the low, it's um distension and constipation more.
So you have to be very clear, as if you are creating a tabular form to answer the question. Now, if
Okay.
I'm to ask you a question in an oral exams, I ask you, define intestinal obstruction. What is high obstruction? What is low obstruction? How can you differentiate them? That is how a question can come. So you have to be highly organized. You define intestinal obstruction. You mention the landmark for differentiating high obstruction and low obstruction. Then you now mention the difference. Okay, when you mention a particular feature, you now say vomiting, for example, as a feature in high obstruction is early, in low obstruction is late. For example, you see, you pick a feature and you give the difference. Don't just be random. You have to be highly organized.
Yes,
If
sir.
you mention two, distension in high obstruction is absent or minimal. In low obstruction is marked. Another feature, constipation. In high obstruction is late. In low obstruction is early. Another feature, fluid and electrolyte derangement. In high obstruction, it is marked. In low obstruction, it is less. So this is how you answer questions so that you will be highly organized. When you
Okay.
talk about high obstruction, the obstruction occur, it involves up to the proximal ileum, okay? Upper part of the intestine involving
Yes, sir.
up to the proximal ileum, okay? Upward, that is high obstruction. Now, low obstruction is distal ileum and the large bowel. That is why you see bilous vomiting in a high obstruction. And you see feculent vomiting in a low obstruction. When you say feculent, it means fecal, but in a liquid form. The difference between feculent and fecal is the consistency. Because in the low obstruction, most of the content is already fecal, but is already in the terminal ileum or the distal ileum, it is in a liquid form. While in the colon is either semi-solid or solid. So that is the difference. Now, because the vomiting is early in high obstruction, okay, because it's involving the upper intestine up to the proximal ileum, they lose a lot of fluid, they lose a lot of electrolytes, so they go into fluid and electrolyte derangement very early. Okay, because there's a lot of electrolyte in the intestinal secretion, gastric secretion, biliary secretion. Okay, so they vomit a lot. So because the vomiting is early, distension is either absent or mild, because they vomit the content that is proximal. Okay.
Okay.
Yes. So, most of the fluid are absorbed now in the large intestine and it becomes solid. Okay.
Yes,
so
sir.
that is your own questions. There are several other questions, but during our word rounds, where we'll be discussing most of these things on patients. As I told you, clinical medicine is learned by the bedside. Reading books alone will not make you physicians. You must be by the bedside. Clerk your patient and present your patient. Okay?
Yes, sir. Thank you.
Now, the second presenter, your own question. What are the features of intestinal obstruction on a plain abdominal X-ray? What are the features of intestinal obstruction on a plain abdominal X-ray? Yes? Is the second presenter with us?
Yes, here.
Yes, go ahead.
I know of air fluid levels. Like, I think on the X-ray, you're going to see as if there's air inside.
What do you mean as if there is air?
They're going to be
Aha. You
okay.
see, you presented the management. I brought up this question just to draw your attention on the important stuff, relevant investigation at your level, and what you will be asked. Some of the investigations presented, they are not things that are routinely done. Okay, you might see them in the textbooks, but they are not routinely done. In fact, they are not even done, some of them you mentioned. Like a patient presenting with acute intestinal obstruction, you start doing maybe NMR or contrast study. We don't routinely do that. Okay, there are some basic, simple investigations you do that will give you an idea of presence of intestinal obstruction, and you now do others to determine the cause of the obstruction. Okay. So one of the
Yes, sir.
common investigations in acute intestinal obstruction is plain abdominal X-ray. Plain abdominal X-ray. Now you should know plain abdominal X-ray is requested as erect and supine in a patient with intestinal obstruction. Okay, it
Yes, sir.
presents as it is requested as erect and supine. Now you must know all the features that are looked for, okay, in both the erect and the
Yes,
supine.
sir.
Now, the erect X-ray will show multiple air fluid levels. The erect X-ray will show multiple air fluid levels, okay? Now, you should remember multiple air fluid levels is presence of more than 3 air fluid levels, okay? More than 3 air fluid levels in adults and more than 5 in children, because there are physiologic air fluid levels. The physiologic air fluid levels include the fundal gas, okay? The fundal gas. Then number 2, you have the first part of the duodenum, okay? And number 3, the cecum. Yes, so these are the areas where you see air fluid level. So now when you start seeing air fluid level more than 5, you know it is pathologic. More than 3 in children, more than 3 in adults. In children, because of swallowed air, you have to, or breastfeeding, during breastfeeding, it's more than 5. Remember, air fluid levels are seen in what erect X-ray. You see multiple air fluid level. Okay. Then in supine, it shows the character of bowel that is obstructed. Now, if it is small, what do you call it? If it is small bowel obstruction, you see a centrally located bowel with what is called volvulae conventis. Centrally located bowel with volvulae conventis. Okay? Is it clear? Are we together?
Yes, sir.
Okay.
Yes, sir.
Centrally located bowel with volvulae conventis. Okay. Now, if it is large bowel obstruction, if it is a large bowel obstruction, you have haustral markings. Haustral markings. Okay, let me show you what I'm talking about. Can you see the whiteboard?
Yes, sir.
Can you see the whiteboard?
Yes, sir.
Okay. I said for small bowel obstruction.
Sir, I can't see the board.
Okay, you can't see it. I just shared a whiteboard. How many of you can see it?
I can see.
I see it.
I can also
So
see.
how
I
come she
can't.
can't see it? You can't
Okay, so I
see it?
can see it now.
Okay.
I can see it now.
Okay. So in small bowel obstruction, there is centrally, sorry, the writing is not coming out good. This centrally. It's not from me. They say doctor's handwriting are not good. It's not from me. It's from the whiteboard. Centrally located. Okay, I think it's the network. So I'll just stop the whiteboard. You can just write it. Centrally located dilated bowels. That is for small bowel obstruction. Then you have volvulae. Volvulae. It's not writing properly. Volvulae conventis. Okay. So volvulae conventis is you see concentric. Okay, let me see if I can demonstrate. You see a bowel with transverse radio opaque markings, just like step ladder. Okay, transverse radio opaque markings from one side of the bowel to the other. That is volvulae conventis. While in a large bowel obstruction, you see haustral markings, dilated bowels that are peripherally placed, not centrally placed, they are peripherally placed. And the haustral markings are incomplete, unlike volvulae conventis. So these you see for large bowel obstruction. So you see the erect just shows multiple air fluid levels. The supine will show the character of the bowel that is obstructed. If it is small bowel, centrally located bowel, dilated bowel with volvulae conventis. If it is the large bowel, they are peripherally located bowel with haustral markings. Okay, so now, there are some investigations we don't routinely do in intestinal obstruction. As I told you, NMR is not routinely done. Ultrasound scan is not routinely done because ultrasound scan, it's a scan that works with echo, sound waves. And in a distended bowel, you see there is gaseous distension. And you know the echo, the sound wave don't travel smoothly on gas, so it disperses the echo. There will be no reflection to be picked up by the transducer and give you a good quality representation of what is happening. Except in children, it's not common. It's not you. We don't use it in adults. Even in children, it's not in all cases, except in interoception that is commonly used, where you see target sign when you are suspecting interoception. You see a target sign and a sausage-shaped mass. Okay. Then contrast study is not commonly done. Now, we won't go into much details into this discussion because this is your first presentation on a topic like this, but over time, we are going to talk more and discuss more on this topic. But if you have any question or any clarification, you can ask before we call it a day. So if you have any question, just go ahead and ask. Any question? Okay, I believe there are no questions. There are no questions? So in the absence of any questions, we are going to stop here. Who are the presenters for tomorrow?
Sam presenting tomorrow.
Okay, who and who?
I and Esther.
Okay, what is your topic?
Classification and management of intracutaneous fistula.
So everybody have had the topic, so you are supposed to read it. Everyone read so that you have meaningful questions and contribute. We're going to call it a day now, and that will be the end of the presentation. So by tomorrow, God willing, we are going to continue. Thank you very much, everyone, and good night.
Thank you, sir.
Thank you, sir.
Yeah.